It's my distinct pleasure to introduce Kyle Foreman, who many of you know. Kyle, for those of you slaving away working on CODEM, Kyle created CODEM.
Don't shoot me.
Blame Kyle for that. You can also, Kyle was the first to develop what's now become GBD Compare and our suite of visual tools for GBD. He was a PBF and then a data scientist with us and is now finishing up, I think, soon.
Yep.
His PhD at Imperial in Biostats and Epidemiology.
Yes.
Very good. And you're going to, I'm sure, wow us with something new.
Thanks, Chris. Yeah, as Chris said, I'm working on my PhD right now at Imperial and with Majid Azadi there. And I'm doing small area estimation of causes of death and some novel aspects to it that we haven't done before and things like CODEM that I'll go over. Oh, my computer froze, sorry. So I'll be going over what the goals of my dissertation are, and then a little bit about what the sort of data I'm using, and then finally what the model itself is and a little bit of the results that come out of it. So my goal for my dissertation is to analyze cause-specific mortality trends at the US county level, and then not just to estimate one particular cause, but actually jointly estimate the cause-specific mortality. So instead of doing separate models for each cause of death, just having one big model that does all of them at once. And then in addition, not just do retrospective estimation, but also to forecast forward into the future. So the data set I'm working with is every US death certificate dating back to 1979, which is when ICD-9 began. And we have the actual microdata here. So it's the full death certificate, minus things like the name and address, but down to, it gives you the county and the exact age, and most importantly, it has multiple causes on the death certificate. So instead of just having the underlying cause like you would normally have in, for instance, the WHO's published aggregates, we actually can look at each one and see everything that led to the death. This one, can't really read it, but that's Kurt Donald Cobain's death certificate. So the data has a lot of different dimensions to it, which I'll kind of demonstrate here, which first we've got time. So this is just the age-adjusted mortality rate, total across all causes of death. You can see gradual downward decline. We've also got age pattern for this. So that's the log mortality there. We can break it down by sex, so look at the sex ratio. We can, of course, do spatial, so this is at the county level. This is, again, 2010, the all-cause mortality, age-adjusted. And finally, we can look at it by cause of death. So this is a tree map, if you haven't seen one, which breaks it down by proportion and into different groups. So we can break it down across all these ways, but what makes it particularly both interesting and complicated is that we actually have interactions across all these. So this is, if you look at it across time, you can watch how all of this changes. And so ideally, we'd like our analysis to take into account all of these relationships in maybe one model, maybe a few models. So the first thing I've got to do is decide what is the universe of causes of death to use. We start with just all-cause mortality, and then we'll break it down into the 3 standard groups you'll often see, which is we've got the group 1, 2, and 3. So communicable, and we throw perinatal and maternal in there, the non-communicable diseases, and injuries. For the US, don't break down communicable disease into that many because you start getting small numbers issues. We don't have to worry about malaria here, fortunately. But these are the 5 categories in which we can get sort of sufficient numbers to really model them. And then for non-communicable diseases, there's the categories there. So the big ones, of course, are cancers, cardiovascular, diabetes. There's this mental and neurological category, which is sort of problematic, but that mostly encompasses things like Alzheimer's and just general dementias, which are increasingly being encoded on death certificates. Then we break down cancers into 5 categories and then a remainder. Cardiovascular, again, we do ischemic heart disease and then stroke. Don't separate out the kinds of stroke, and then other cardio. And then injuries, as you'd expect, is intentional and unintentional. And then you have homicide versus suicide, and then road traffic injuries and everything else. If you've ever spent more than a few minutes with Mosin, you've probably heard about garbage codes. And that's not as big a problem when you're dealing with US data as if you're dealing with global health data, but it's still an issue. And so here I've got an ICD-10. I've broken it down into 9 different categories of garbage codes. And as you can see, the biggest of any of them is heart failure, which is over 2% of deaths in the US are coded to heart failure. Next up is ill-defined cardiovascular, which is mostly hypertension. And then there's the rest. ICD-9, the problem is even bigger. Things like hypertension show up as the underlying cause of death on over 4% of death certificates. And if you start looking at just like the older ages, in females, it's almost 8% are coded with that. And it doesn't really offer any useful public health information, right? To say they died of hypertension. It was a contributing factor, but we want to get at the actual underlying cause. So we do what Mosin has coined the term, I think, redistribution. And so first we look at, how does garbage compare to the other causes of death? So yeah, it's not huge, but it's bigger than the group 1 or group 3. This is, again, females 85 plus and ICD-9. So it's definitely a problem we have to take care of there. So we want to put these deaths somewhere, but we want to put them somewhere that makes sense. So what I do is I look at the other lines on the death certificate and then additional factors such as do they die in or out of the hospital, what's their age, male versus female, all those sorts of things factor into one big logistic regression to predict if they had the underlying cause listed as, for instance, hypertension, what was the most likely actual underlying cause. And so once we do that, you can see all of them jump up a little bit, but most of it goes to group 2, which makes sense because we were looking at, ill-defined cardiovascular was one of the major ones, which for the most part should go all to group 2. To give an idea what that actually looks like, here's where the garbage goes. So over here we have before redistribution, and that is the 20% of garbage right there. And these lines show which codes it actually ends up going to. And if we focus in on 1, this is the ill-defined cardiovascular, and most of it's going to ischemic heart disease and stroke. Other cardiovascular, a little bit goes to renal failure and diabetes. And so this is just sort of a way to look at what actually happens to all these deaths so that in the end we can have just a quote-unquote clean set of data to work from. So once I do all that, I end up with these historical trends. So that's the first part of what I'm going to look at. is how have things changed over time, which I can do both at all the way down to the county level, the way it's prepared. Here I've just sliced it up into 8 regions, which if you read any of the US burden of disease papers, these are the categories they use there. So for instance, right here, we're looking at, in females, lung cancer versus breast cancer. And right away, you can see some interesting things. For instance, where it crosses. So in some regions, it's already crossed, and others it hasn't. Where that would be where lung cancer is now killing more 45 to 54-year-old women than breast cancer is. You also see some interesting things like, for instance, Rocky Mountain area, very low levels. And that's because of low tobacco consumption there, particularly amongst the Mormon population. They don't smoke, and so much lower lung cancer there. We can also smooth these out to make them a little easier to read. And then we can look over time. Over age. So if we go up, you can see in these ages, lung cancer, you can see a clear peak where tobacco consumption peaked in probably the 50s or 60s there, and then has been on the decline since. And you can just watch the cohorts as we go up in age. So this is 65 to 74-year-olds, 75 to 84-year-olds, and 85 plus. Sort of interesting is, the Rocky Mountain is no longer much lower in that one. Probably some sort of cohort effect where smoking was not as uncommon in the past for this age group as it was for others. So there's just hundreds of different little stories like this you can look at. On this one, you can also look at the far west and see that it sort of evened off, started declining faster than most of the other regions. Far west includes California, which has had stricter tobacco policy. So there's things like that to look for in this data set. This is just one example, and hopefully at some point I'll have time to go through and actually write papers about all these things. But right now, like I'm about to do now, I've moved on to the actual modeling of it. So the goal of the model is to predict the number of deaths in a state or a county. So that's S for spatial, for a cause of death at a certain time point, certain age group, certain sex. So that's what we're trying to predict. You'll see that I don't have age and sex on there. That's because for now we've ended up doing separate models by age and sex, which is really just sort of a computational shortcut. Also, it's once you start thinking about what the different cohort models are in this and then interacting across age and time, number of parameters balloons even more than the already huge number that's in this model. But that's kind of a step for future research is to combine those. So predicting the number of deaths, again by space, cause, and time. And we use a Poisson likelihood and a big Bayesian model. And so what we want to come up with is this parameter mu, which is our estimate of the deaths in each of those groups. So we, as standard in a Poisson model, we model the log of that. And then we offset it by the population in that spatial temporal area in order that we're now modeling rates. So that offset takes out all the effects of population. This first line of parameters are the intercepts. So like in a standard regression where you have an intercept line which affects just the level, that's what's going on here. And I'll break down what those specific parameters are in a minute. then we have a slope. So across time, how is it changing? And this is a piecewise linear regression. So this just means for the first piece. So up until a knot year, which is like 1999, you use one slope. And then after that, you use another slope. And they don't really share any information there. And then the last component is a random walk, which is the nonlinear portion of the time trend. So we have for each state, for each geographical unit and each cause, there's an additional component that picks up how is it changing over time that's not reflected in these linear trends. So across the intercept, part 1 and 2 of the slope, we have just a global offset. This parameter, it affects all of the states, all the causes, counties, all that. And so that's basically just your constant term in a standard regression. Then we have some spatial parameters. And what these spatial parameters do is they account for, across causes, how does each geospatial unit differ from the national average. Then we have the same thing across causes. So how does each cause differ both in level, in trend, these two pieces, and then the nonlinear portion of the trend. And then finally, there's these interaction terms, which say for a given geospatial unit and cause, how do they differ? So that's like we were looking at that issue of California or Utah, where they have very different levels of lung cancer than other places. You need some sort of interaction between cause and space in order to capture that. So first I'll go over the spatial terms. So we've got the alpha and the beta terms there. Again, the alpha is the intercept and beta are the slopes. So what we're doing here is we're using, it's called a Gaussian Markov random field, which if you know what Gaussian process regression is, it's basically the same thing where you're using random effects, but they're correlated in some way. So for instance, how you use GPR in the GBD stuff is that's enforcing correlation across time. This CAR model, as it's called, conditional autoregressive model, we've set up to enforce correlation across space, which means that adjacent areas are forced to have similar random effects. Now the standard way of doing a conditional autoregressive model is you say, well, here's my parameter in county I, and given all of the surrounding counties parameters, just take an average of that. The Gaussian Markov random field version, instead of doing each county independently like that, you just use a giant multivariate normal to model that effect from. And the strength of that is that then you have the joint distribution and you can use some more interesting sampling methods. The weakness is it's really computationally intensive. So there's some trade-offs there, but another nice thing about it is, so this is your precision matrix that controls how correlated the various random effects have to be. And it has, in order to make it proper, you add in this parameter p. And what p does is it allows you to say how correlated should these random effects be. A standard CAR model, you don't have quite that amount of control. And this p lets you say, well, in some cases you want a lot of correlation between spatial units and some less so. So to give you an idea what that looks like, this is lung cancer in males 55 to 64. And these are the random effect parameters just for the intercept. So if p is 0, then you're not enforcing any smoothing. That's basically just a standard IID random effects model. Like if you ran a random effect model in Stata, this is the value of the random effect. But once you start bumping up the value of p, so that's p 0.2, 0.4, you can see that it starts smoothing out a little bit, especially in the red area is probably the easiest place to notice it. Go up to 0.6 and 0.8, and then once you get up to about 0.9, it's really obvious what's happening here, which is that you're forcing adjacent areas to be more similar. And that's probably good, right? Because we have very small numbers in a lot of cases where we have, within a county, within an age group in a year, you might have 0 deaths most of the time, or just a couple. And if you didn't enforce this smoothing, if you go back to here, you can see there's lots of, just little ones jumping out, really different from their neighbors. And it's probably not that they're actually that different, but that the data just isn't there to support that. And next are the cause parameters. So again, we have an intercept for each cause, that's the alpha, and then piecewise linear terms for each. And in this case, tried a few different ways of doing this, but what I want to do is enforce some sort of, I guess you could say, smoothing across causes. Basically, we want to borrow strength between them and say that, well, some causes are actually similar in terms of how they change over time and space and age, whereas others are just totally uncorrelated. And so what we do is we, again, model this instead of just a standard IID normal random effect where they don't interact with each other. In this case, we use a multivariate normal with this inverse Wishart precision matrix. Don't worry about what that is, but what it means is that you can come up with a posterior on what causes are related. So this is our list of causes in order there. Sorry, it's a little small. And then it's a square matrix. And dark values mean they're correlated, and light values mean they're uncorrelated. And so that's you might see some patterns there. Like we've got this cluster right here of IHD, stroke, other cardiovascular, and chronic respiratory are together. And then up here, lung cancer is also correlated with them. But we can make that easier if we then use a clustering algorithm on them. And now instead of using the sort of etiological relatedness to order them, we say based on the posterior of their random effects, how similar are these causes? And then you get some interesting patterns here. So this cluster in particular, you have other communicable with HIV, homicide, and liver cancer. Which, if you just asked a physician to group things together, that's probably not going to be your first group, right? Because they're very different etiologies behind them. But if you start to think about what are the risk factors that lead to these, it starts to make more sense. Same thing with, you've got lung cancer over here, clustering with IHD and other cardiovascular. And that's, again, probably just, it's picking up the effect of tobacco. So what's nice about this is it shows that even though I'm not including covariates in the model, it's actually picking up through relatedness between diseases a lot of these joint effects that you would expect.
Kyle, just on that first block that you highlighted, what sort of common risk factors would you think of? Other communicable, HIV, liver cancer, and homicide?
Yeah, I think
homicide is the really odd one out there, I would think.
I could think socioeconomic status, poor areas,
Yeah, but that's a post hoc explanation you can think of for almost any grouping.
Yeah, and well, but that's the nice thing about this, right? Is if the data supports that they're correlated, they come out correlated, and I'm not enforcing anything on here, right? This is just what's the result of that parameter. Yeah.
So, when you get the correlation matrix?
This is the correlation matrix.
Yeah, but what model? You're using the correlation matrix in your model.
Mm-hmm.
But then, what model are you using to obtain the correlation matrix?
So it's just, the prior on it is just like a non-informative inverse Wishart.
So you're using a model, you start with a model which says they're uncorrelated. You fit that model, you get random effects, and then you use a sample distribution of the random
No, this is it's just one model. It's not like multi-stage or anything. This is just, when you fit the model, this is what it's decided when it's fitting it is the best correlation structure.
Oh, so you're fitting the correlation coefficients in your model?
Yes. Yeah, this is fit in the model.
In the likelihood.
And this is accounting for, the spatial effects and all those other parameters that are in the model.
There is one thing that's second stage, right, which is the clustering, which actually it didn't do as well as it could have.
Yeah.
You should have put in your poverty cluster, road traffic injuries, renal failure, and suicide.
Right. Yeah, so you can see there's a second block that's also correlated there.
And their voice areas are inversely correlated or not?
Yeah. So it ranges from basically -1 to 1. I think the highest negative correlation I see in the data is about -0.4. So those aren't highly negative, but the white ones are negative, yes. And so this structuring that I'm showing you, where I go from this, which is just ranked in the order that I named the causes, basically, to this, that doesn't have any actual effect in the model. So the model is just this covariance matrix, and then the ordering is just to make it clear to you what's clustering, but that's not actually going to influence the model itself. Mm-hmm.
Did you clean the database and run this process?
Yeah, so all of this model is running after the garbage distribution I talked about, and I don't know what other cleaning is really necessary. We don't have many missing ages or anything like that they're used to.
Clean, for example, when we are talking about cancer,
What do you?
specified site cancer.
Yeah, so that happens in the garbage code research. I have a package that's just ill-defined cancers, and then you look at what other things are on that person's death certificate and determine what's the most likely actual cancer that they died from.
So how many causes did you have in your?
So this is 24 causes, and these are collectively exhaustive, mutually exclusive. So everyone who dies goes in one and only one of these bins.
Okay, so you have 24 times 23 over 2, something like parameters.
Yes. And that's just for this matrix.
Right, just
Yeah.
the matrix.
Yeah, no, there's a lot of parameters. I'll get into how to fit that. Yeah.
So I understand the redistribution of costs of that, but could you say briefly how you did the geographic redistribution, or did you have access to actually?
I had data at the county level, so I didn't have to do any of that.
So there is, though, coding for cases where there's very few deaths for cause or very small counties where that data is not publicly available. So you get it from NCHS? Or
Yes, I have the NCHS data, so that's not an issue here.
Well, I mean, their public data doesn't have those. So
Yeah, no, this is a different. We have all the micro level identifiers. Yeah.
Why aren't they all square? So because when it is covariance, it should be symmetrical. So why some boxes is not square?
It is symmetric. I think it's just the aspect ratio here isn't quite square, but
And then I count the number of cells of 3 times 1, 2, 3, 4, 2. It's a box 2 by 5. Like a middle one.
so this 3 by 5 box matches with this 3 by 5 box. It's only along the diagonal they have to be symmetric.
The strongest thing for me is the strangest is diabetes.
Yeah, so
Everything, and then it comes up
Mhm.
with HIV to B. Doesn't come with anything else. Something that's
and even then it doesesn't really yeah, it's basically uncorrelated with everything. Yeah.
But to be fair, this is for a specific age and sex.
This is for males 55 to 64, and so I have a different one of these for every age and sex group.
That's forceful, though, because that age group.
Yeah, no, I would expect more to pop out, but it's just saying once you account for the other effects, it doesn't show up. Yeah.
Question about going back to the smoothing thing. Is that in any way weighted by sample size or population?
It's not an explicit parameter in there, but the Poisson likelihood over the entire model makes it such that the counts do come into play
Are you
there.
estimating a posterior amount, or are you just specifying this?
I'm estimating a posterior on it, and it normally comes out around 0.9. And so you actually have to put a strong, and so there's a strong prior on having it greater than 0.5. And that's sort of the standard for these sorts of models. If you don't, if you don't have a strong prior, it's always going to pick IID because it can, fit the actual data points better, but it won't have any spatial correlation.
Coming to the values, if there are there any other that you have, and again run these because other is a heterogenic.
Mm-hmm. Yeah, no, the remainder categories are
Yes.
an issue in general.
If you there are other and then again make this cluster, maybe give you a better.
It's true, but if I don't include remainders, I have to put them somewhere, right? Otherwise, it's not a collectively exhaustive list, and then you can't estimate total mortality from it.
Find correlation between this group.
Mm-hmm.
Okay, other is a very heterogeneous causes. You cannot find any relationship between other non-communicable diseases.
And that's fine, right? Because so the goal of my analysis, this is just a byproduct of it. This is not the purpose of the analysis. It's just an interesting byproduct, and you can see what's happening under the hood. But the goal is to produce these mortality estimates, and so you need the remainders in there.
So to touch back on the spatial stuff, maybe just let me know your view on this. Is maybe not as a good solution, but Markov and appeals, you're just using the adjacent counties, right? So there's situations which those counties may be very distant from each other in the western states and very near to each other in the eastern states. So in the eastern states, you may actually want to have a further search than just adjacent in the western states. So I don't know if there's.
So you can set that up in the adjacency matrix.
Yeah.
So basically, the way I'm doing it is zeros and ones, whether or not they're neighbors. You can set up actual weights there. It gets complicated because I'll get into later. I have to do a sparse matrix, so I can only do 0 and 1. But you can also just include, count neighbors of neighbors in some areas. I don't know that it's really necessary, and I think then it adds another analyst choice into the mix, which, but it'd be easy to add. I'm skeptical of how much it would really contribute, but because those counties are also oftentimes more populous than even the giant, very sparse Wyoming counties. But I think the CAR model is nice in that it actually uses just adjacency and not actual distance from like the centroid, as if you were using like a standard GPR, because that doesn't really matter, right? It's more like who your neighbor is, not how far away in space if you're in the rural area. All right, I'm move on. So those other terms I had in there were interactions. And what those are is for each cause, there's an additional Gaussian Markov random field, which is basically a map showing spatially how do these units differ by cause. So it gives you the spatial pattern of deviation within a cause, which is important because, like I was saying, with California and lung cancer, you need those specifics there. Otherwise, basically you'd have just a state level and a cause level, and you wouldn't really get any differences between in your ultimate outcome. And then the last terms are these nonlinear trends. And these are just random walks. And so what the random walk does is you just have a zero-centered parameter, and then you just sum up the one before it, all the ones before it, to get your estimate. And what that results in is you get a nice funneling of uncertainty. So when you're in sample, you're going to just have each step isn't going to move too far from the last one. And then when you're out of sample, the uncertainty is going to funnel out. But because I also have those linear trends in there, it will still have the mean following what was happening in sample. So the random walk doesn't affect the trend so much as just the uncertainty. And then in sample, it gives you nice fits to the data. So computationally, this model is difficult to fit. As you saw, there's thousands and thousands of parameters in there. And if you try to use something like WinBugs or like PyMC2, you can put an adaptive metropolis sampler on there and let it run for days, and it won't get anywhere. It'll just stay at your priors. So I've had to use some different techniques to actually get all these parameters fit. So first, sort of a compromise I had to make was to do separate models by age and sex, which is just how do we pare down both the number of data points and the number of parameters to make it estimable. And the decision was we'll use age and sex because I'm sure some of you will argue about this, but I think there's less strength to borrow across those. Yeah, no, I hear some groans right now already. So we can throw down afterwards if you want. But I would probably say, well, there's less information to borrow across cause, but the whole point of my dissertation is to model causes together. So can't throw that one out. And then time, clearly there's a strong trend there, and I'd argue that spatially as well, especially if you want to do small areas estimates, it's necessary. Which kind of just leaves age and sex as the odd man out. So I use NUTS for this. NUTS is the No U-Turn Sampler, which comes out of Andrew Gelman's group at Columbia. And it's a relatively new sampler for Bayesian hierarchical models that is pretty awesome. It's a form of Hamiltonian Monte Carlo. And what it does is it utilizes gradients to optimize in these highly multidimensional spaces much faster than you'd ever be able to get with a standard metropolis, for instance, or a Gibbs sampler. So kind of an analogy is, say you're trying to find the highest point in a field, and MCMC, like metropolis, is sort of like you throw a frisbee a random direction at a random distance, and you see where it lands, and you say, how far or how high is that? Is it higher than where I am? If it's higher than where you are, then you go to that spot, and then you throw it, but you don't turn as much, and you don't throw it as far. Whereas HMC, it uses gradients, and then what it does is it's like when you're trying to find the highest point, you turn in a direction, and then you just throw the frisbee, and you got a little rangefinder in it, and you find along the path of the frisbee, not just where it lands, what's the highest point, and then you just go to the highest point there. So you've kind of reduced the burden of that of finding the point. You're searching less blindly, and it works great. The problem with HMC in general is that there's a lot of little parameters you have to tweak on acceptance and rejection probabilities, and how much do you turn each time. But what NUTS does is it takes a lot of those questions out and uses algorithms to find the optimal sampling parameters there. And it makes it so you can find the best way to sample in this space without having to try a bunch of different versions. The problem with any of these HMC ones, if you're using the gradient, is that it requires the joint distribution, which means that you can't do Gibbs sampling, which is if you've used bugs, that requires Gibbs sampling. So you take a step and then you look back at the last one, and for instance, for the car model, that's how that works. You say, what is the mean of the random effects surrounding that county in the previous iteration? But you can't do that in an HMC model. So what that means is, for instance, you have to do that multivariate normal, the GMRF version of the spatial effects, which the issue there is it becomes extremely computationally intensive again. For instance, you've got a 2,000 by 2,000 matrix, covariance matrix, to fit that multivariate normal, and that's really hard to invert and therefore draw from. To do this, I've been using software called Stan. It's also out of Andrew Gelman's group. And it's written in C++, but there's bindings for R and Python that you can use, even MATLAB, I think. And it's basically like bugs in that you can just use a pretty simple model specification language, and then it'll come up with the distribution, with the posterior for you. And it has different sampling algorithms. The main one is NUTS, but they have maximum likelihood in there and all sorts of others. And what's really nice about it is that it's vectorized and it's compiled, which means that the software, instead of looping through every observation, every parameter, it can do them jointly, and it really speeds up everything over bugs. It's, just for a big model, I found it literally hundreds of times faster per iteration, and each iteration gets closer to convergence. So it converges after fewer iterations, and each iteration is faster. So it's just kind of wonderful for big, complex models like this. The last thing I had to do is do a sparse matrix implementation. So going back to what we were talking about, the spatial things, is sparse matrix implementation basically says, instead of inverting this giant 2,000 by 2,000 matrix, you kind of just loop through which pairs are ones and ignore all the zeros. And using that, I was able to speed up the sampling of my model by 30 times. So it still takes, to get convergence, takes about, at the county level, about a week. So if I didn't have that, I would not be giving this presentation right now because it would still be running. And that, I've posted that to the Stan list, the sparse matrix stuff, if you want to test it out. All right, on to the results. So these are the predictions and the data at the national level, age-adjusted rates, both sexes combined. So I'll give you a minute to just kind of look over these. And what you'll see in general, though, is in-sample fits are mostly very good. There's some where it overestimates. But in general, I'm pretty pleased with how these turn out. Keep in mind, these overestimates are not because it's not fitting this particular data well, but this is an aggregate. We fit it at the county level and then have aggregated up to the national level. Similarly, it's fit for each age and sex, and then this is aggregated up to age-adjusted and both sexes. But what you see here is, like I said, in sample it fits pretty well, and then out of sample, for the most part, what it's going to do is take the last 10 years or so of data, fit a slope to that, and then balloon out the uncertainty with the random effect. And all these estimates, again, are at the county level. Here I'll show you Washington State. So toggle between these a little bit so you can see the difference. And you see you do get, like if you watch, I think renal failure here in the middle, you see that even the slope comes out different at the state versus the national level.
You have an ICD-9-10 problem. Yeah. Failure and see
Yep. Yeah, so, yeah. Yes, no, I agree that, yeah. So anywhere we see these messes, I've spent a long time trying to get rid of those, especially other cardiovascular. This is the worst one. And I've spent hours tweaking ICD codes and
If you use distribution.
yeah, but mine doesn't make up numbers, so. But actually, but I do need to give a lot of credit to Mohsen because all of the ICD-9 and 10 mappings that I've come up with were based on his epic work on the GBD mappings. So I took his as a starting point, and then most of the time I just kind of condensed down into causes that were of interest and had adequate numbers for the US, and then did a little tweaking around the edges. But for the most part, as in terms of what I classify as garbage and how I set all these up is all thanks to Mohsen's work.
Can you go back to national for a second?
Yeah.
So it looks like some of them are coming down, and then in the projection, they sort of head back in the other direction.
Such as?
Renal failure is a good example.
Mm-hmm.
So what's
So-
going on there?
So renal failure is there's large differences between states and counties there. And so what's happening is at the national level, some states are going up much faster than the states that are going down, or counties, and it's often the larger states or counties that end up doing that. And so once you aggregate up, you get these sort of counterintuitive trends. Same with if you look at the total mortality, again, because it's aggregated across causes, if you just fit a model to total mortality, it's basically just going to be log linear decline. You can see in this case, it starts to smooth out here. And in some age groups, it actually starts to come back up, largely because causes like mental and neurological are going up so fast, whereas the ones that are declining aren't declining as quickly. So yeah, by modeling at the micro level and then aggregating up, you see some of these trends that you can't necessarily see in the macro data.
I was going to say at the tail end of all these causes, the second derivative is positive. It's not a single one where it's just straight.
Yeah, and so in fact, most of that is due to modeling in log space, which it's kind of what you have to do, right? If you don't model in log space, you either come up with negative numbers or then it looks even wackier. And yeah, so I don't know that there's really a solution for that. And I've tried. But yeah, that's sort of what happens.
Did you say which age and sex?
So this is age adjusted across sexes.
Okay. By doing separately by age, have you actually checked what age patterns you get to project?
Yes.
Because that could become pretty wacky.
Yeah, but there's enough data that, I mean, as long as it's fitting this close to the data, the age pattern that pops out is.
Well, you're projecting 10 years, but if you would start projecting 20 years,
Yeah.
I suspect it will get some rather strange patterns where in one age group you happen to go a bit further in one direction or in
Right. Yeah, no, that's a fair point. That's the problem with any forecast, though, right?
What other cancers that your care is simply above data?
Yeah, so I'll have to look further at that one. I think it's, again, an issue of at is that the other cancer cluster, first of all, the ICD problem sort of messes with things. And then it's also related to, at the county level, some counties being outliers being much higher than others. And those bring up the national average. Yeah.
Were you plotting means or medians?
Medians with a 95% confidence interval. Yeah, so I aggregate at the draw. So each draw I sum up, and then I find the median at the last point. Yeah. Mm-hmm. So I just used 2010 population because I'm doing rates, so it doesn't really matter. I mean, it will affect the uncertainty a little bit.
Doesn't it matter insofar as the distribution?
Yeah, no, that's true. Yeah, so for national, that does change. And so that's, AB and I have talked about this before, is what to do with that. Because you can get forecasts from the CDC, but those are at the, excuse me, are only at the state level. So and then to try to take some model to put those at the county level, I don't know the best way to do that, unfortunately. This works at the county level, which is in an actual publication, those will be more important. But yeah, I mean, the headline number is affected by that, unfortunately. So a little bit of validation. So this is the absolute median relative error. In sample, 2%. And this is across average or median across age groups and across sexes at the national level.
Can you tell us how you're doing this?
Yes, so in sample, so what I do is I hold out the last 10 years. In sample is how it fits the data from 1982, which is what I picked up because there's problems with the counties before that. 1982 through 1999, and then out of sample is 2000 through 2010.
And this is at the county level?
At the county level. But this number I'm showing you here is the national one.
What's the county?
I don't remember off the top of my head, but I can pull up the spreadsheet for you later. But yeah, so I can look at it by county, across counties, the average across counties.
Have you validated the small area part by?
Not yet.
I mean, your map at the beginning,
Mm-hmm.
When Roe was low, you had Duluth, which actually, if you know, Minnesota should have higher lung cancer than
Mm-hmm.
the surrounding areas, and then you make it go away with your putting the Roe up to where you're using it.
Uh-huh.
So I sort of suspect that has a massive overkill effect,
Right.
forcing this spatial homogeneity that doesn't actually probably exist. So it'd be interesting
yeah.
to see how you come up, how do you figure out how to validate that?
Right. Yeah, I mean, so it's, whenever you, just by modeling them together, you're going to have this sort of regression towards the mean. And then by imposing smoothing, you're going to get even more of that. So, that's a trade-off with any model, though. Sorry?
So the problem is, so the reason you want to smooth, of course, is because there's small numbers and stable estimates over time. So you believe that the neighbors are informative, but in some cases, in large counties with stable trends, you don't believe the neighbors are informative.
Well, I mean, the fact that the Poisson likelihood should take that into account. I mean, all the small parameters, the more data you have to inform any one parameter, the less it's going to be smooth towards the mean. Yeah, so and there's the coverage. If I fit, for instance, the same model, but without the cause components, fit it with just the spatial and the temporal patterns without including any of the cause information, just aggregating up, you can see you do get better, but not radically better out of sample performance in terms of absolute error, but not only do you not have those specific estimates to inform you, coverage is also much lower. And yeah, you can come up with, I'm sure if your goal was just model total mortality, you could come up with a much better model than my cause model pulling out causes, but that's just sort of one little test to show that it's just showing that by modeling causes together, you improve it. I also have a model that's running right now which does each cause separately and then aggregates them up, and I'm going to find out if that does any better. So definitely including cause information, it doesn't radically hurt the overall predictions, and it drastically improves coverage. Then the question is whether jointly modeling them is that effective. And I should know that soon. So these are all my collaborators in London, and then here, particularly Mohsen for all his work on those ICD maps. It's just an amazing amount of work, and it's great. And then AB's been a sounding board on a lot of this, which I appreciate. So thanks very much.
I don't know if you had the chance to explore your results, but were there any major findings there?
The most interesting one is that in some age groups, the decline in mortality in the forecasts really levels out, and in a couple cases even starts going up because of some of the causes, which are smaller right now, have a much faster rate of growth than the declines in other causes. So you get kind of a rebound effect on mortality. And whether or not you believe that or if it's just an artifact of the model, it's interesting at least.
Brad, so how does Stan handle constraints?
So there's a long post on Gelman's blog that I'll refer you to, but he says you should never have constraints in models, and it's just poor priors to do it. So I put in sum to zero.
That's his view. Okay.
Yeah. So at first I fit the model with sum to zero constraints on all these random effect parameters. In Stan, it works. It just takes a lot longer to converge.
But what does the Hamilton-Jacobi algorithm do when it hits the wall? You follow along a certain trajectory to the point where I'll look. So you're saying they do have constraints in it?
Yes, they do. And so, if you're just talking about constraints on the parameter, like in the prior, those are also implemented. I was talking more about sort of constraints on sums of parameters. Those are the ones he rails against, but that you can set for any variable. It's just typing like in C, and you can set lower and upper bounds on things. And I'm not sure how it works under the hood.
Transforms go to life.
Oh yeah, that's right. They transform the space into continuous.
Plus or minus infinity.
Yeah, that's right.
Okay.
Thanks.
Thanks a lot.
Very nice. Here's the thing that I worry about. Or not worry. I suspect